SSBMT for organizing this, and I would like to thank Gilead for sponsoring this session. So our speaker today is Professor Antonio Pagliuca. He is well known in the hematology and stem cell transplant. Professor Antonio is a professor of stem cell transplant at King's College London, is the chief medical and scientific advisor of the Anthony Nolan and trustee for Leukemia UK. His role as scientific advisor will be to assist and guide the future medical and scientific priorities for the charity. His past roles include President of British Society of Bone Marrow Transplant, Chair of Bone Marrow Transplant, CRG, and National Clinical Lead for Regenerative Medicine, NHS England, and Medical Directors for King's College Hospital Networked Care Division. As Transplant Director for 19 years, until 2017, he led King's attainment to a center of excellency and one of the largest unrelated cord, haplo, and identical transplant and cellular therapy programs in UK. In 2018, King's became the first CAR-T center in the UK to treat both adult ALL and non-Hodgkin lymphoma, and he has a great role to establish this. He has published widely on hematological malignancies, stem cell transplantation, and infections in this patient group. Also, he has a special interest in management of infectious complication pre and post stem cell transplant. So it's a pleasure for me to introduce Professor Antonio. His title today will be The Evolving Fungal Landscape for Managing Fungal Infections with Hematological Malignancies. And he's going to touch also the impact of COVID-19 infection about this topic. So Professor Tony, welcome. You can start.
Welcome and salam alaikum. Thank you for the great opportunity to be with you this evening. It's always a pleasure having visited some of the faces I know well. Here we are. The meeting is sponsored by Gilead. The outline of the talk this evening, which will probably be about 50-60 minutes, is looking at some of the risks associated with fungal infection, some of the old risks that we all recognize, and some of the new risks, and how this might change our practice. A focus on trying to understand your own epidemiology, as I will describe our epidemiology of fungal infection at King's. What diagnostics do you have available to you in a timely fashion that may help you make a diagnosis of fungal infection? And then a very important topic, perhaps most on the resistance issue, a little bit about toxicity we can discuss, and then how all of this will feed into your likely antifungal policy. And the big debate which has been going on for 30 years, which is empiric therapy or not, and that is a thorny question. So I think, as I said, for many, many years, most centers were really using empiric therapy, partly because the diagnostics available to them were poor, and very few centers were using a diagnostic-driven strategy. But with the advent of prophylaxis, and many of you will be following either some European or American or GCC guideline, where prophylaxis is now standard in a significant proportion of patients, should you be using a diagnostic-driven strategy, or should you be using empiric therapy only? I think trying to think about how you might go about understanding what you should be doing with particular groups of patients, I call this the risk escalator. This is a slide from Livio Pagano, looking at the populations of patients, and we can categorize them as either low risk, intermediate risk, or high risk. And the classic group of patients that you and I treat in hematology and transplantation are in that top group of high risk patients: AML, MDS induction, and allogeneic transplantation. And in the lowest risk down here in the left-hand corner, you have our stem cell transplants for myeloma and lymphoma, and then a middle group of patients, which includes ALL, which would be considered intermediate risk. Now, I have added two different new areas in this intermediate risk. One is CLL with treatment with ibrutinib, CAR-T checkpoint inhibitors down here, And then an interesting problem now, not specifically a hematology problem, but the fact that our hematology patients can get influenza and sadly are also getting COVID-19, and this puts them into a new risk category. So we'll touch on that later. So I think there are a whole host of parameters that one might think about in the risk stratification for antifungal prophylaxis. And here, I'm not going to, you can read these for yourselves. There are genetic markers, geographic factors, climate, which is obviously pertinent to living in a dry and climate versus a humid climate, environmental exposure, is there building work going on in the area of the hospital? Are there other factors within the soil that may make that a risk? Some metabolic factors, viral and bacterial co-infections, and we're going to touch on that with COVID-19 and influenza, as I said. And then an interesting area which everyone's heard about, the microbiome, but there's also the mycobiome, with data suggesting that many patients are already colonized with these organisms, and the infection risk comes from there. So in every different hospital around the world, people will have a view of how they're going to manage these patients. Should I just treat the confirmed cases, wait until I've confirmed the diagnosis, and therefore only treat the patients who need treatment and not risk treating them with drugs that may have toxicities and of course have a significant financial toxicity, versus the idea of prophylaxis over here in the left, where you're going to treat a hell of a lot of patients, but to reduce the risk for just those 4 patients. But I suspect the most of us are in this middle bit here, with prophylaxis for some, and then the idea of empiric and perhaps even preemptive if the diagnostics are available to us. So I just remind us that there are quite a lot of guidelines. This is just one in particular. This is the ECIL 5 recommendations for bone marrow transplantation, ECIL being the European Conventions of Infections and Leukemia. And you can see here, I think for me, the most important bit of this guideline is that historically, many centers use fluconazole alone, but in this setting, they are A3 against the use of fluconazole if the patient has high risk or GVHD, and their advice is to use antifungal prophylaxis, and specifically you can see here it's posaconazole, and in some even posaconazole as pre-engraftment, as we do, and I'll talk about that later. And certainly in AML it would be posaconazole prophylaxis. So the paradigm has now changed, and therefore how we manage these patients may have to change. But I think what has transformed care for many of us, and we're all having access to these novel immunomodulators, small molecule inhibitors, monoclonal antibodies, and cellular immunotherapies that are transforming the outlook for many hematology patients, and indeed many other cancer patients, are that these are not benign treatments and not without their own risk. Although they're not intensive chemotherapy, they may not make you significantly neutropenic, but they may indeed have issues. So if I think that from the day I qualified, and that's a lot of years ago, I started medical school in 1977, we have been giving mainly chemotherapy-based treatments, but some of these targeted therapies here, and I'm sure you're using most of these in one form or another, the TKI inhibitors, FLT3 inhibitors, sorafenib, quizartinib, gilteritinib, midostaurin, crenolanib, then the anti-BCL2 agent venetoclax, gemtuzumab, blinatumomab, inotuzumab in AML, and CAR-T for cellular therapy here, and a whole host of agents in lymphoma, including venetoclax and ibrutinib, and combinations of these agents indeed also with checkpoint inhibitors. So the whole paradigm has shifted, and the risks of infections has also changed, and some of these drugs also have other toxicities that we can focus on. So you can see here, this is a sort of schema of the possible targets in the B cell receptor through the typical flow, BTK, PI3 kinase, AKT, then through to the nucleus. But this is a pathway that is now being attacked at multiple levels. So you can see navitoclax, venetoclax, as I said, ibrutinib, acalabrutinib, dasatinib, idelalisib here, and on the surface the monoclonal antibodies. But these are novel, showing great effect, but also having significant toxicity risk. So although you say, well, what's this got to do with fungal infections? Well, actually quite a lot, because although we are targeting the hematological problems that we treat on a daily basis using these very targeted and very useful agents, some of which are transforming the outcome for these patients, these agents, dasatinib, Rux, Tofa, ibrutinib, idelalisib, sorafenib, also affect our body's ability to protect us from fungal infections. And so what we're now seeing is a sort of dissection of fungal immunity, and many of these agents are causing increased risk of fungal infections. Now, that's fine. You say, well, I know that, but it's quite not really that fine, because that many of these patients are not being treated as inpatients with intensive chemotherapy. They're being treated as outpatients. So we're starting to see problems that were, by some people's expectations, unexpected. And here is an example of a paper published in Blood of fungal infections associated with ibrutinib. And not just one or two patients, but actually a significant proportion of these patients, nearly 20% of patients, were developing a fungal infection in this study. And it wasn't even that it was just the classic respiratory fungal infection with aspergillosis, but they were seeing significant CNS disease. And in a paper associated with this, they showed that ibrutinib may permit invasive fungal infections through multiple effects. And you can see here that it's targeting different points in the protection armor that we have against fungal infections, whether it be neutrophil abnormalities, whether it be priming of T cells, or whether it be inactivation of the macrophage toxicity towards the fungus. So what appears to be a very simple agent that is targeting the B-cell receptor has other deleterious effects on the fungal immunity risk, and therefore we are seeing that. And here's a paper looking at across a whole spectrum of lymphoid malignancies, and with ibrutinib monotherapy in CLL and non-Hodgkin's lymphoma. And you can see, although the risk of fungal infections here in purple is only 4%, the totality of fungal, bacterial, and viral infections means that 1 in 9 patients is at risk of infection. So we need to be aware of that and manage that appropriately. So I've already touched on this to some extent, showing that the last decade or so has been transformational in the care of our patients with hematological malignancies, and that these new therapies are coming thick and fast. But one of the issues, though, that although they increase the risk of developing a fungal infection because of interactions with our ability to control fungal immunity, they are also having other side effect problems which have an impact on how we are going to manage some of these patients. And that's where we need to use a mold active azole, either as prophylaxis during intensive therapy. And you can see here ibrutinib, idelalisib, Rux, then the TKIs that we use in CML, and then the FLT3 inhibitors, and then obviously here venetoclax. And there is a significant interaction, mainly inhibition of CYP3A4. And what does this mean? Well, it increases the exposure to many of these drugs. And on a recent talk, someone did a very nice presentation of a publication showing significant problems with Rux treatment in patients who are having intensive chemotherapy combined with Ruxo. And of course, the paper didn't even focus on the fact that the patients were all on mold active azoles. So what was happening is they were using mold active azoles, giving Rux at standard dose without reduction, and seeing massive numbers of cytopenias. So not only is it having a toxicity on the marrow, it's also having cardiac issues with prolongation of QTc. So I think you now need to seriously think at all times of having your pharmacist associated with you giving these treatments and making modifications. One of the positive effects for us, certainly at King's, is that we're using a lot of venetoclax in our acute myeloid leukemia and MDS patients who relapse post-transplant. And if we give posaconazole, then we're reducing the dose of venetoclax by 50%. Some might even argue there is some data suggesting might even reduce it by 75%, and therefore the cost of the treatment reduces dramatically. And here just to show why one might consider using some azoles rather than others. And here is a problem. Voriconazole has significant toxicity. We know voriconazole can cause lots of issues with hallucinations, skin cancers, etc. And the cleanest of the products is either Posa or isavuconazole because it only inhibits CYP3A4 and is not a substrate for any of the others. So I think when you're thinking about which azole you might want to use, you're probably going to want to consider either Posa or isavuconazole as the least toxic agents if you're using it in combination with those other therapies. And here is a couple of papers looking at this FLT3 and dose modification that you would have to consider. And obviously gilteritinib is now also licensed from Astellas. And you can see here, if you're, and this is an old-fashioned azole, ketoconazole, but if you're using keto plus midostaurin, you can see that the area under the curve is dramatically higher than placebo plus midostaurin. So here are a whole host of other drugs as well that can have that interaction. So you do need to be careful in prescribing these patients. An area that, of course, many hematologists say to me, well, what do I care about immune checkpoint inhibitors? I've used it in the occasional patient with Hodgkin's, but that's about it. There's some use in patients post-allograft to augment DLI. But on the whole, this is a treatment that is used by my oncology colleagues and with great effect in patients with melanoma and other cancers. But one of the important things about the immune checkpoint blockade drugs, nivolumab, pembrolizumab, is that they cause an inflammatory process in many different organs. So I call it checkpointitis. You name the organ, there is an inflammatory process if you give a checkpoint inhibitor. So why is it a big problem from the point of view of fungus, or is it a problem? Well, it is sort of. The reason being that if you get the inflammatory process in one of the many organs that it can cause problems with, then the standard of care is to give corticosteroids or infliximab. And here a study from MD Anderson looking, Memorial Sloan Kettering, sorry, showing that in 740 patients, the risk of fungal infection was there, mainly infections with a small proportion of them developing fungal infections, say less than 1 to 2%. But we need to be aware that that is a risk, and therefore our colleagues in oncology may ask us, or they may ask our ID colleagues what to do in these patients. So they need to be of heightened awareness if they're using these agents that there is a risk of infection and indeed fungal infection. And something that's a little bit closer to home for us hematologists is when we're using CAR T therapies in patients with lymphoma and in ALL, and now with the license for mantle cell lymphoma and the licensing for myeloma not being far off, you can see that we're going to be seeing far more patients with this. Now, CAR T causes cytokine storm, so it causes the neurotoxicity, the hemodynamic instability, and the organ dysfunction driven by IL-6 and interferon gamma. But what's of interest here from this paper published from Carl June, showing that in patients who had grade 0 to 2 CRS, that cytokine storm increased your risk of developing a fungal infection or infections in a third of cases. And if the patient had very severe CRS, then nearly 3/4 of the patients were developing an infection. Now, as I said, is it they're all developing a fungal infection? No, it's not that they're all developing a fungal infection, but they are all developing significant numbers of bacterial, viral, and indeed fungal. Why is fungal an issue? It says here 4%. This is out to 28 days. We see in about a third of our patients protracted neutropenia out past day 100. And these patients are therefore at risk. They have neutrophil counts of less than 0.5 for many months, and therefore they should all be on posaconazole or other similar azole prophylaxis to ensure that they don't run into problems. So at the end, I'm just bringing this up just so that we can, as food for thought, and we can have a conversation at the end of this talk about this. Have you seen this sort of problem with your fungal, with fungus in some of the novel therapies that you're using, ibrutinib, venetoclax, or combination of both, and what issues, and we can discuss that. Perhaps you've seen none of these, and that it really isn't a problem, and perhaps I'm overemphasizing, but it is something that we need to be aware of. No talk at the moment, and I think the UK government is saying just as we speak that the UK is going into, or England is going into, a full 1-month lockdown again because the numbers are rising dramatically. You'll never hear me say that COVID-19, SARS-CoV-2 is like the influenza. It is definitely not. It's far more serious and far more dangerous, and is causing major issues. So there are some pathophysiological similarities and differences. Obviously, the SARS-CoV-2 enters the cell through ACE2, angiotensin-converting enzyme 2, and some of you will have seen a publication this week showing that it also enters through neutrophilin 1. But there are two portals of entry for COVID-19. It typically enters the lower tracts and causes significant damage and thrombosis down in the lower respiratory airways. Flu can do that, but it also affects the larger airways, so you can get a tracheobronchitis, and that is why you also see it associated with fungal infections in the tracheobronchial areas, not just the lower lung. And flu A can affect the immune response. We now also know that it can do that. It causes this pronounced lymphopenia, which we see, and indeed in some neutropenia. And these chemokines that are responsive after that cause a lot of the toxicity that we see. And when I first saw the first cases, and our first cases were in February of this year, so just as we were setting up the diagnostic test, the 50 patients who were the apparently negative test, 2 turned out to be positive, which was a bit of a shock. But in the first few weeks, we were seeing lots of patients with sagittal views on CT scan here, showing what I would have initially said was a fungal infection, but we now know the ground glass changes associated with COVID-19, but probably also a fungal infection at the same time, although we didn't have that evidence at the start. And here, and obviously colleagues in the GCC and in Saudi will have been will have managed some of this in the past. So you've got to start on, as you understand this rather better than perhaps we did to start with, that both fungal infection and aspergillosis have been observed in patients with both SARS-CoV-2003 and the MERS COVID virus. And so I think now we are starting to see multiple reports of SARS-CoV-2. And here a table of a number of examples from many countries, including China and Europe. And I think the most important thing to note here is, I'm not trying to say that it's from this one study here, that in 35% of patients in Belgium, where they have excellent services who are looking quite hard at this, they did find invasive aspergillosis in those patients to some lower numbers, around 5%. But either way, in this population of patients, especially the ones who have been on intensive care for 4, 5, 6 weeks, I think the risk is very, very high, and we need to look aggressively to identify it and then treat it appropriately. And we have, because we were aware of that, we're looking at our ITU population. This is a random cohort of 85 patients on intensive care with COVID-19, looking at serial galactomannans and serial beta-D-glucans. And we were finding positive results in those patients. Typically, as I said, not immediately, but when the patients have been neutropenic and quite unwell for a period of time, then at an average of 3 weeks afterwards, we were seeing both of these coming up positive. So what does this mean? Well, I'm not sure exactly, because having a positive galactomannan or beta-D-glucan in itself is not a diagnosis of a fungal infection. But if the patient has clinical features associated with a fever, associated with a CT scan that looks suspicious in the absence of a BAL or a biopsy, then these patients are all falling into the probable group of patients. So we think that this is an issue, and we're tidying up this data for publication. And of course, at King's, it really was a major issue for us. And although at the moment the numbers are much lower, with the second wave actually starting, we are very worried. At its peak, we had, these are the weekly admissions of general and acute patients coming through the front door and patients being admitted to critical care. So remember, these are cumulative. So at the peak, and we have now managed over 3,000 patients at King's, we had at the peak, and the peak was in this week of April, around Easter, and I was on call that weekend as the Gold Commander for the Trust. We had 565 inpatients with COVID-19, and about 130 of those were on intensive care. So we were really pushed. Our normal intensive care bed capacity is 60. We doubled it up to manage this issue, so we were being pushed very hard. But it wasn't just a London phenomenon. It spread, unfortunately, quite quickly to the other urban conurbations in the United Kingdom: Newcastle, Leeds, Manchester, Sheffield, Birmingham, Cardiff, and the London conurbation was the hardest hit by a long way. And in that first phase, and this is data through to the 18th of June, when we look at the case fatality rate, for the UK as a whole, it was 40%. But you can see here for King's, the Denmark Hill and Prue site, we were in the about a quarter of our patients were dying. And that was, of course, both patients on intensive care and on the main wards. And one of the reasons I think that across the UK, in much smaller units, they did not have the capabilities. They didn't have ECMO available to them, and some of these patients succumbed because of poorer access to some of those treatments. And we were, of course, running a lot of the trials. So I think our case fatality rate was lower because of that. But even though our case fatality rate was lower than the national average, the one thing that didn't really change was what we all recognize, which is, unfortunately, the older patients are doing far worse than the younger patients here. And this holds across both sexes, for both male and female. So that remains true today, and I think it remains true in just about every data set that I've seen. So, but one of the interesting things for us is that age by itself is not the only important parameter. Now, for transplanters in the room, you will understand what the Charlson Comorbidity Index is. We use that as a marker in all our transplant patients to give the patient some idea of the high risk or low risk of the procedure, and to give them a number. And you can see here, by using the adjusted Charlson Comorbidity score on 1,673 patients coming through our front door up until the 11th of May this year, we were able to also show that there was a steep rise based on the comorbidities that these patients have. So bad actors do badly, and it doesn't matter what disease area you're talking about. But the frightening thing is that the mortality, case fatality rate in this population up here is, you can see here, 6 and above is over 40%, which is really very serious. Now, what happened in the UK is we quickly, through our national society, then through the EBMT, then through American guidelines as well, which we were all following the same sort of pathway. We quickly switched off all our autologous transplants, except for the very high risk ones that we needed to do. And indeed, we switched off a significant proportion of our allogeneic transplants. Here are two data sets. This is from January to June 2019. And here we are, the same data set from January to June 2020. So you can see that the amount of activity in this 4-month period, March, April, May, was dramatically lower. And this has been a serious issue, because not only have we had to delay treatments, perhaps some patients indeed have come to harm across the country, not getting their autograft on time or not getting their allograft on time. And we have seen problems where donors have become positive, recipients have become positive, and we've I'm not going to present this data. We have a whole slew of data looking at the immune profiles of these patients. But the bottom line is we've had a significant issue with COVID-19. And I suppose the discussion towards the end is, for you, the question from me to you is, has this been an issue for you? Have you had to see a reduction in transplant activity? Which patient groups have been most affected? And have you seen this co-existent fungal infection? And are you in Saudi planning for a second wave, or have you been fortunate enough to dodge the bullet, as they say? So if we go back to the question of the risk of the population that we're treating and the epidemiology, because I hear many times colleagues say to me, well, our centre, we don't have major problems with a fungal infection because we're very good and we have better laminar flow facilities. And I say, well, it really depends not so much on the facilities, but actually on the group of patients that you're treating. And so this is a nice score from Marta Stanzani in Bologna, looking at over 2 time periods, showing that there was a progression over those 2 time periods, i.e. that they're starting to treat more and more high-risk patients, multiple relapses, relapse post-allograft, etc., etc. But the bottom line here is the 4 simple drivers of this risk. One is neutropenia, where you get 4 points. Previous invasive mycological disorder, you get 4 points. Malignancy status, in remission or not in remission, and then the lymphocyte count. Now, actually, you could probably use this score for COVID-19, I suspect, and you'd probably get a similar result, which is that the more points you score, the higher the risk of you having a proven or probable invasive mycological disorder, mold infection. So I think you need to understand what's happening in your own service rather than me telling you what's happening in mine, but that can be helpful. And that data is also supported by the idea here from, this is an Italian study, there's a big American study as well, looking across many, many different transplant centers and showing that some of the larger centers have a very high risk of invasive fungal infection, but so do some of the smaller centers. So the bottom line is you need to understand what's going on in your department as to how that might impact on the way you manage this cohort of patients and what algorithms you put in place or standard operating procedures you put in place. Because the most important thing that comes out of this, and I'll show some data later from ourselves, is that if you get a fungal infection, then it is actually going to shorten your life. The risk of what was written down as the primary cause of death was 44.7% in this population of 1,858 patients. So I think we need to take it seriously. Some people say, well, they didn't die of a fungal infection, they died of acute leukemia with a fungal infection. But actually, when they did an apportionment of the cause of death, it was quite high in this population here. So at the time, we, I suppose, ourselves didn't really know. We thought we knew the risk of our population of patients. So we did a study. This is Mansour Cisse's paper, which started actually in the early 2000s. By the time his thesis was done and recruitment and the data were analyzed, it was published in BJ Heme in 2015. So 203 patients recruited over this time period. And both allograft and chemotherapy patients with significant follow-up and a lot of investigations. At the time, we were using itraconazole, but we threw the kitchen sink at these patients, CT, Galactomannan, beta-glucan. We used the lateral flow devices early on, the first phase of that, PCR, biopsies, and then to try and understand some other potential biomarkers, which we've published on. We're using cytokine array, but we won't touch on that today. And perhaps it showed us what we thought, but at least we had some hard data at this point that in our allograft program using itraconazole as prophylaxis at the time, our rate of infection was 16%. In our aplastic anemia population, 14%. In our chemotherapy, and a lot of our patients are not really de novo AML, they're relapsed refractory AML, it's 12%. But as we might have expected, in our autograft program, it was quite low, 3%. And similar data to what we saw from Corrado Girmenia study in the allograft program. Remember, this is a prospective trial, not so we were collecting all this data and we analyzed it. So I think we feel confident that all the patients who could have gone in did. And you can see here that patients who did not have a fungal infection were significantly better off from the point of view of overall survival than patients who did. So proven and probable IFD significantly reduced your survival. So the argument goes, best not to get a fungal infection. And here, the possibles are not classified, were intermediate. So again, confirming what we've seen from other studies. So a fungal infection is quite bad for your health. And another piece of data that we just finished publishing on, and we're just about to publish on a much larger cohort now, looking at the baseline CTs in these patients. We've always felt that many patients who are referred to us from other centers have a higher risk of infection because they've actually already had a fungal infection, but no one identified it as such. So we did baseline CTs looking at normal scans and abnormal scans. This was by 2 blinded respiratory radiologists from the Royal Brompton Hospital, and then classified using EORTC and non-EORTC abnormalities. And you can see here a dramatic increase in risk if you had classic features. So these patients it was not about prophylaxing them anymore. They actually had a fungal infection at the time and therefore needed to have full treatment. So that changes how you manage these patients. So another very important assessment. And I think this paper is published a few years ago now, but I think it still holds true. If this is from MD Anderson, so over 4 time periods, showing that when they did autopsies in these patients, to start with, a long way back, they were finding fungal infection in 32% of these autopsies, and that had reduced to 19% by 2004-2008. But the frightening thing is that even with the improvement, only 51% of these patients were having the fungal diagnosis made in life. The rest was only made when the patient died. So again, pointing to the fact that we're not very good at diagnosing these patients. We're all aware of the EORTC MSG criteria, proven, probable, and possible. They're great for studies, but not necessarily always that straightforward in clinical practice. Reason being that the vast majority of our patients are rarely proven, occasionally probable, most of the time possible. And if I was to put another category here, which is not sure, most of our patients fit into the not sure and possible categories most of the time. And that's because we may or may not have all the armamentarium available to us for the diagnostics. So for some, it would be, yes, we can do a sputum and we can do a calcifluor on that. That might be helpful. I think it is for some. Fine needle aspirate, open lung biopsy, rarely available in many centers. It was for us. We did 45 VATS biopsies in our patients. Bronchoscopy should be routinely available to everyone, but I joke and say that you ask a respiratory physician to come along and do it, and he says, I'll do it on Monday, and by that stage, the patient's too unwell, and they say, sorry, it's too late to do it. So we don't always get this result, but I think this can be very, very useful, especially if this is combined, the BAL, with Galactomannan assessment antigen here, or beta-D glucan. And of course, the mainstay for most of us is the CT scan. And I suspect in most institutions, we're making a diagnosis of fungal infection after 96 hours of bacterial treatment. If the CT scan looks suggestive, then we typically say we think it's a fungal infection, although I think you need to be able to prove that in your own center. Now, many centers around the world will have Galactomannan available in their laboratory, but is it available in a timely fashion? Reason being, if you look at the cutoff index of 0.5, it's got a very good sensitivity and specificity. And this is in immunocompromised, mainly hematologic patients. They do need to be neutropenic when this test is done, with a median prevalence of 7.7% in this Cochrane review. But one of the problems with modern therapy is, of course, we're typically using antifungal prophylaxis, Posa, Itra, Vori, isavuconazole, whichever is your fancy. But either way, the sensitivity of the test is dramatically reduced, down by 37%. It doesn't mean it's no good. It's just that you need to be aware that it is less sensitive. And that just means, though, that if they are on prophylaxis, you probably need to be doing this test 2 to 3 times a week. And when the result comes back positive on prophylaxis, you know you have a breakthrough in these patients. So again, just a discussion point later on, what diagnostics do you routinely have available in a timely fashion? and I mean timely fashion. There are some colleagues in the UK that say, yeah, we can test with Galactomannan and BD, and the test result comes back in a week's time. Well, that's no use to man or beast. That's an irrelevant test if you can only act on it in a week's time. You need it in a timely fashion. By that I mean either 24 to 48 hours should be what you should be looking for. So the sort of last run of the topic before we get to the finale, as I call it, is to understand resistance. Everyone's focused on antimicrobial resistance, and perhaps people less so on antifungal resistance. This is a very nice paper from a collaborator, Matt Fisher, who's at Imperial College, looking at, and it's got nothing to do when I was born, when it started medical school in 1977, but looking at the correlation between plants and humans by countries around the world over this time period of 40 years. And what we're seeing is, in parallel, we are seeing significant increases of resistance in the plant world, and that's also in the farming world, where in animal husbandry, in cattle, in pigs, in lots of different animals, where they use antifungals as well as antimicrobials. And we're seeing in parallel a similar increase in human beings. The reason for this is that many of the drugs that are used in plants are nearly, not quite, but nearly identical to the ones that we use in human beings. So we are seeing movement from the plant world into the human world, and this is going to have a major impact on our ability to treat patients with fungal infections. And this is really nice data that was given to me by Paul Verwey in Nijmegen in the Netherlands, looking at the resistance, and they do resistance monitoring routinely in the Netherlands in the big centers. And you can see here a frightening increase of resistance over a 5-6 year period. In this one center here, up to 20.8%. By 2018, 1 in 5 of the isolated aspergillus organisms was resistant, and resistant to typically voriconazole. And the vast majority of these are environmental, coming from the animal husbandry business and the farming business. And Paul has shown very nicely this data of how it spreads between the two. And this has had a dramatic impact on the outcome of patients, looking here both hospital-wide and specifically in hematology. And you can see here 21% reduction in the survival of these patients if they had a voriconazole-resistant organism. So I think it has made them have to really rethink their program in the Netherlands. They historically would be using fluconazole prophylaxis. They've had to reconsider that. But even if they continue using fluconazole prophylaxis, the moment they get a sniff of the possibility that the patient has a fungal infection, then they are going down this route. So of course they do the CT scan, they consider starting Vori, Isa, or posaconazole, they try and get a BAL and do a Galactomannan on that, but the vast majority of the time they're not always able to get a BAL, as you heard earlier. And the Galactomannan is not greater than 0.7, it's just greater than 0.5. But then they're not always able to isolate an organism, and therefore they can't see whether or not they have azole resistance that's greater than 10%. And you saw from my previous slide that some of these centers have azole resistance of greater than 20%. So the bottom line is they start here, go there, and in rapid time switch to ambisome as the only useful treatment that they now have in this population of patients. They also saw this in their ITU population with influenza A, where they had 29% resistance. So this has been a transformational moment in Holland for the management of fungal infections. So they're now finding that the only agent that they have available to them that they know can be sure will give them the spectrum of activity they need is ambisome. So I'm not trying to say that that's happening in your center or it's happening in my center. I don't think we have that level of resistance. However, it is something that you do need to seriously consider in your own center as to how you're going to manage these patients. So you end up with this idea of, okay, well, what are we going to do? What's our policy in Riyadh or Jeddah or Dammam? But is it just going to be primary prophylaxis and that's going to be fine? And then we need to think about whether we're going to give a treatment? Is it going to be empiric or preemptive, only for confirmed for breakthrough? What diagnostic tests are we going to have available to us? And are there patients where we might consider secondary targeted prophylaxis, as I showed in our data set, where you have a patient who has a baseline CT that is grossly abnormal? That patient isn't having prophylaxis, they're having secondary targeted therapy stroke prophylaxis. So we try and risk stratify our patients, looking at the risk factors that we all recognize, and we do a diagnostic driven strategy, and then we categorize patients into low, standard, or high risk. Our low risk patients, those are the patients who have had an autograft, just get fluconazole. The vast majority of patients in our own center, from our own data set of it, an epidemiological data set, are greater than 7%, so nearly all of them fall into the high risk category, and then a middle ground of patients who, on the whole, I suppose for simplicity, we are giving many of these patients mold-active azole, except for the ALLs, of course, where we can't use an azole, and in that population of patients, we're using ambisome on a thrice weekly basis. Although the AMBI-GUARD study did not show superiority, it did show a trend for the use of amphotericin, liposomal amphotericin B in that setting. So are we any closer to understanding what we should be doing? Right at the start, I showed you a slide saying, should we just treat the targeted patients and reduce the cost of treatment? Is prophylaxis the right thing to do? Well, it is for certain high-risk groups where you should be using it. But then this middle ground, which is driven by prolonged fever plus these diagnostic tests, so that you try and reduce the number of patients that you're going to treat. It would be no different than me saying to you, so you've got a patient who you think is at risk of CMV, and you just decide to start treatment based on what? You wait for the CT scan to be abnormal? No, you're doing diagnostic tests. You do the CMV PCR perhaps twice or 3 times a week, and the moment you get a positive result, you start appropriate treatment. So I think we have to fall into line with that in the fungal world as well, and the diagnostic tests are important. But just to the final few slides, there are some people keep going back to this study from Catherine Cordonnier in Paris, who's the PREVER study, looking at this idea of should we use empiric fever-driven versus preemptive, and that it will save a lot of money, and patients were given liposomal amphotericin B, or in those days actually just standard amphotericin B, but many of them received liposomal product. So which is better? Well, when this study is presented, typically, Catherine typically just shows this slide on the left, which says there is no difference between preemptive or empirical therapy. As you can see here, the overall survival with these patients is the same. But I prefer to focus on this side, saying that actually, if you look here, the patients in the empiric arm had a significantly lower risk of developing a fungal infection. So, well, but if the overall survival is no different, who cares? Well, I care, and so does the patient, because we've shown already from our data and many other sets of data that patients who develop a fungal infection have a much higher risk of death. And if you get a fungal infection, it just complicates everything thereafter. You sometimes have to delay therapy, you have to give 4 to 6 weeks of therapy before you feel comfortable to make the patient neutropenic again. So that's supported by this data here, is prevention of IFI is better than cure. So looking again here, this is from Corrado Germania again, showing patients who induction chemotherapy who didn't have an IFD, here we go. Patients who did, significantly worse survival. And so the important thing is that we should be trying not to put our patients at risk. So we should be ensuring that we're prophylaxing them and we're acting aggressively to manage fungal infection, because if we can do that through that first induction, once they've achieved CR, then there is no difference. But it's aggressive management in this early phase is warranted to reduce that risk. So this is our IFI management algorithm at King's. We review it on a yearly basis and update appropriately if there are new agents available to us. But the bottom line is that we are believers in prophylaxis, and we use posaconazole prophylaxis in the vast majority of patients. As I said, in ALL, we would be using ambisome. And we are doing the mandatory tests here. on a routine basis, and if required, we're getting the bronchoscopy and other CTs of different organs, and occasionally now still doing the VATS biopsies, but we have cardiothoracic on site. And using the parameters of galactomannan beta-glucan, there's a high likelihood we go down the ambisome route. If it's negative, we might consider ambisome if there are non-specific infiltrates and we get a biopsy. But if there's no pathology defined, then we will review the use of ambisome. And if pathology is defined and we don't think ambisome is the right drug, then we would switch away from it. But if there is no infiltrate and we don't have typical features, then we won't switch away. We won't give empiric therapy, or sometimes we start empiric therapy and then we reverse out so that these patients can continue on prophylaxis, which, as you all recognize, posaconazole prophylaxis is the same as posaconazole treatment, and we have done levels on these patients and they usually have very high levels. So I think as I said, the EORTC MSG criteria are great as guidelines and for studies, but whether or not that's useful in our daily clinical practice is another matter. This was a slide I picked up when I was in Russia 30 odd years ago, when the communism was falling at that time, and obviously Karl Marx and Engels and Lenin clearly thought the theory was right, but it didn't quite work out. So it's understanding what you think is happening in your department and coming up with an SOP that works for you to try and reduce the risk, because getting a fungal infection is bad for you. But certainly in our hands, ambisome has been a very effective agent, and we've been using it since the early 1990s. So we have a lot of experience. In my view, toxicity is minimal. There are some patients where we do see problems and we do have to switch away, but on the whole, we do not. So here's a few things, and thank you, and happy to take any questions.
Thank you, Prof. Tony, for this excellent and comprehensive review of this topic. And you touched also about the COVID-19 infection and post-transplant. So we will open now the questions while we are waiting for any questions.
Professor Alaska has asked about venetoclax can cause prolonged severe neutropenia. What is your experience with it, and do you always use antifungal prophylaxis with it? There we go. Not always. As with any patient, if the neutropenia is projected to be more than 7 days, then and the patient is having a combination. Now, we would typically not use venetoclax alone in AML and MDS. We give it either with decitabine or with azacitidine, and typically in those patients, those patients are going to have, as Dr. Alaska says, a very significant prolonged severe neutropenia, so we would use posaconazole prophylaxis. But if I was using venetoclax in a patient with venetoclax and ibrutinib in the CLL setting, then some of those patients are being managed as an outpatient, and we are just monitoring them in the outpatient setting. If the neutropenia drops below, people use 0.5, but I say in the outpatient setting it has to drop a little bit lower than that before we would consider antifungal prophylaxis. So not routinely in that population of patients, very aware that they are at higher risk, but in the AML MDS, typically because many of these patients are elderly, they may have relapsed refractory disease, or they're post-transplant in a 60-year-old who's relapsed at 7-8 months out. We use this as a bridge to next treatment or to DLI. Then in those patients, yes, we use antifungal prophylaxis.
Okay, thank you, Prof. Tony. I have a question. Is there any risk stratification system that's used to judge on starting antifungal prophylaxis?
Well, I mean, there are some people that, so the Bologna score, or some people, there was a publication called the Bologna 2 score. Well, it's not been formally published, but where they try and stratify based on the Bologna score. So patients who fall into the 2 lower categories, you can perhaps manage without prophylaxis. Patients who are in the higher risk categories, prophylaxis. But the bottom line is that most guidelines have been driven by diseases and the publications associated with them. So obviously the 2 publications, Oliver Corneli and Andrew Ullman's publications in New England over a decade ago in AML and MDS and patients with transplantation with GVHD, it's a blanket, everybody gets it. But I think now we are faced with as you described, I suppose what we're getting at is we're faced with a whole new scene of drugs where the risk is not clear. And we therefore need to make an assessment in our own services and look at any data that's coming through from trials to see whether or not we should be considering mold-active azole prophylaxis. Let me give you an example. When the CAR-T program started at King's, I was very clear that we should be using mold-active azole prophylaxis in all patients. And a number of my colleagues said, yeah, but that's overkill. Why do you need to do it? Most patients won't get neutropenia. And I said, but the problem we have is that you're not monitoring these patients in the same way as we do an acute leukemia patient. Once you discharge a patient, you're seeing them in the clinic once a week or twice a week, and people aren't focused on the fact, because they're an outpatient, that the neutrophil count is now, they're neutropenic. So we had to have what I always say was the first case who developed a severe, serious fungal infection for everyone to say, you know something, it's a blanket policy now. Everybody gets posaconazole prophylaxis. So you will have different centers around the world advocating for no prophylaxis other than fluconazole and switching to mold-active azoles only when the patient's been neutropenic for 7 days, and other centers just saying, just give them the mold-active azole right from the start.
Okay, thank you. I have another question, practical question. You know, we have, like, if you have acute myeloid leukemia patient who is for stem cell transplant while he's receiving induction or first consolidation, preparing him for transplant, then he develop fungal infection, either proven or probable or possible. Then he will be started on antifungal infection. So when you see him for clearance for transplant, is there any like time duration that the patient should receive or finish with this antifungal medication, either for invasive candidiasis or invasive aspergillosis?
It's a good question, and it's the difficult question of how long is a piece of string. So in the vast majority of these patients, some would suggest, and I've heard a number of people say this, and our view is about 4 to 6 weeks worth of appropriate therapy with a neutrophil count. But for some patients, they don't have that time. The risk of relapse could be significantly high. So I think in those, if you can afford to wait, you would like to see clearance. One of the things from the thesis that Mansour wrote, our own data shows that repeating a CT scan too early is the wrong thing to do. You need to wait 4 weeks before you repeat the scan to show improvement in the lesions on the chest X-ray. If you do it sooner, and there's a nice publication many years ago from a US group showing that if you actually do it within a week or two, the lesion may have grown in size initially before it shrinks. So we would typically, if the patient can afford to wait, give 4 weeks of appropriate therapy. Now, we would prefer that not to be as an inpatient. So in those patients, we are typically now using isavuconazole because it has the trial showed non-inferiority to voriconazole, unless we had evidence that there was azole resistance and that was the wrong thing to do. And if that was the case, then the patient has to come into hospital, or receive either, if we've shown that it's sensitive to either echinocandin or ambisome as an outpatient, which is quite hard work for the patient and quite hard work for the hospital to deliver that on a 7-day-a-week program. But as soon as you feel that you have the disease under control, if the patient is already neutropenic, then you might say we should go to transplant sooner, because doing a transplant will at least get you the neutrophils back. If the patient isn't neutropenic, then I think you have that time to give effective therapy, because the most important thing, neutrophils and an effective therapy will typically work in the vast majority of these patients.
We will have last question from one of attendees, Dr. Mohammed Shahrani. Are you going to interrupt the chemotherapy if patient had an invasive fungal infection and he is in intensification, and for how long?
Well, the answer would be if I know that the patient has an IFI and is on appropriate therapy, then I would try not to delay too long. If the patient has florid disease, florid fungal infection in the chest, perhaps it hepatosplenic disease or sinus disease or cerebral disease, then I would delay intensification chemotherapy. But if the patient just has a few lesions on the chest X-ray and it appears that they are getting better and they're an outpatient, I would bring them in for their next intensification. But during this intensification, they would be on full dose therapy, whether that's daily ambisome or daily caspofungin or another echinocandin, or if, for example, you feel comfortable with voriconazole as treatment, then use voriconazole. I talk about best last treatment. So I think there is no perfect answer for this, because this has to be made in collaboration with your ID microbiology consultants, you understand the risk of the disease and they understand the risk of the infection. But as a team, you have to come up with a plan for each individual patient. So I think it's hard to say, yes, we interrupt it, or no, we don't interrupt it.
Okay, thank you, Prof. Tony. I think we are on time. Thank you very much for this very nice presentation. And thank you to Gilead for their sponsor of today's session. Thank you for SSBMT for organizing this webinars. Just to remind everyone about next week webinar, it will be about GVHD, and we will have Professor Robert Zisser, and I will be also presenting GVHD cases. Thank you for all attendees for attending today's session, and good evening, everyone.
Dr. Al-Rosani, you can at least ask him when you speak to him next week, because he's going to tell you a lot about ruxolitinib, isn't he? And
yeah.
of the other agents. And he can say, so how should you dose modify the azoles? Or how should you dose modify the rux? Because many of these patients with chronic GVHD are in the outpatient setting.
Yeah, and there is interactions with these drugs.
Absolutely. It will be a fascinating talk, but I should come and listen to it.
For sure, you're welcome. Thank you very much, everyone.
Thank you very much indeed.
Thank you.
Good night.
Good night. Bye-bye.